Good morning, everyone. One of the jobs of a Director of Medical Services is to often talk about documentation and wrap people over the knuckles, and it's a pretty tedious thing to do with senior and junior medical staff. My plea today is for us to try and change the world with a slight change to our documentation. You may or may not be aware, but doctors actually write in shorthand. When I see in the record that a patient has a hemoglobin of 74, I know they've got anemia. I can look at their iron and ferritin levels and work out if they're iron deficient. But we tend to just write hemoglobin level. One of the real challenges of this district is that if you look at the documentation in relation to our patients, we have the fittest, thinnest, least morbid patients in the world. And that's really because our doctors are writing in shorthand and we're missing out on valuable money from the ministry to pay for the work that we're doing. This is not just about money, but we also often have nursing staff who are really unclear as to why we're doing what we're doing. So from next Monday, you will start to see a laminated version of this on all of the computers in the clinical areas to provide you some inspiration and advice as to how you can, with a little bit of extra work, and I'm talking maybe 20 seconds, you could be able to really revolutionise our monetary situation and also assist in nursing staff and allied health staff better understanding what's going on. So the first thing is, why are you doing something? Why are you prescribing a drug? Why have you changed the drug? Why are you monitoring a patient? Why is someone being given slow K? I know it's because their potassium level must be low. I can read in the pathology report that it's 2.8, but the coders who code and read every single thing we write in the medical record can't infer that unless we write it. And I'm sure those of you who've worked in larger public hospitals know that this is done as a bit of an art form, and we really need to do it here. Why are you ordering an X-ray? Why are you taking pathology? Why have you changed what you've done? So two things happen. One is the nursing staff know and they can tell the patients and their family, but also the coders know because it speaks to the complexity of the care that we're giving the patient. Signs and symptoms are great to note, but what we need is a diagnosis or a likely diagnosis. So if you wrote in the notes consolidation on chest x-ray, that's shorthand for me to say this patient's probably got pneumonia. But if you write likely pneumonia and you write likely bacterial and you write started intravenous ampicillin or whatever it might be, that explains everything to the family, to the nursing staff, but also allows the coders to code for a likely diagnosis of pneumonia. Now, sometimes we don't absolutely know, but if we have someone with consolidation on a chest x-ray and they've been unwell and we start them on intravenous antibiotics, chances are we think they've probably got bacterial pneumonia and we need to share that in the notes. So a creatinine of 230, what does that mean? Is it chronic renal failure? Is it acute on chronic renal failure? And by simply writing down what you know and infer in a shorthand way in the notes, the nursing staff know, the patients will better know, and then the coders will know, so we're able to get more money for the care that we're giving and explain why we're giving the care that we're doing. If someone is agitated or confused, could this be delirium? And of course, if you start to give them some medication, you put them in a single room, you ask the family to bring in their favourite pillow or use lavender water, that all takes effort and work, and we may even have to have an extra nursing staff. But by calling it delirium, which is what you think it is, that gives us a diagnosis that can be coded for, and that's important. A white-coated tongue treated with Nilstat, I know that means the patient's got oral thrush or probably got oral thrush. Unless you write it, the coders can't code it. So we often see people saying things like, at plan, give IV fluids. I know that means they're dehydrated. The coders don't know that. But if you say, plan, dehydration, therefore needs IV fluids and whatever rate that is, they're able to code that complication or that complexity of the care of the patient we're looking after. The idea around medical diagnosis and principal diagnosis. So the medical diagnosis is they might have been in a motor car accident, but the principal diagnosis is they've had a hip replacement as a result of injuries sustained in a motor vehicle accident, or they're having a hip replacement because they've got osteoarthritis. So my plea today is to A, recognise we speak in shorthand, and B, and we've got senior medical staff support across the district for this, for you to be able to just spend that couple of extra seconds linking why we're doing what we're doing and give a diagnosis to what we're doing. That's really important. Our coders are wonderful people and they're very smart, but they're not allowed to do certain things. They're not allowed to code against a number. So even though it says the hemoglobin is 61, unless you write anemia, they can't code for anemia. If you want to say that there is as I said, potassium of 2.8, you have to write hypokalemia, and it's not an arrow going down in a K, it's hypokalemia, and that is of course important. Because they have that, we need to do extra things for them. They may need to have additional monitoring. We put in additional risk, and that all causes us to do more work, and therefore we need compensation for doing that. So we'll be on the wards in pink tabards, not very many of us, trying to help you do this. And the nice thing is, in about 3 months, we should be able to see our amount per case go up in terms of dollars we can claim through the work that you're really doing. So this is not just about money, but it's really also about making sure that our documentation helps nursing staff and allied health staff to share why we're doing what we're doing with the patients and their family. So hopefully you will help us document the care that we give. It'll take a little bit more time, but the benefits in terms of communication, risk management and safety is great, and we may also get out of our financial challenges by doing this together. Thanks very much.